And I first of all invite Dr. BHENDE to give a talk on evidence in medical management of DME.
Good morning, everyone, and thank you for those who managed to find their way down to the second basement on a Sunday morning. And thank you, Piyush, for inviting me for this meeting. I'll be just spending a few minutes talking on the evidence in medical management of diabetic macular edema. I think this is something none of us disagrees on. It's important to know the patient. And we know that optimum treatment benefit happens only if there's good glycemic control and treatment of other comorbidities, helped by appropriate investigations, and then treatment. I think something for which we now have evidence is differentiating between center and non-center involving DME, where the crucial point is the central subfield zone of 1 millimeter in diameter. And this is what drives all our treatment protocols. So once you have a patient with diabetic macular edema, if it's non-center involving DME, then we tend to go to the good old EDTRS criteria for laser photocoagulation. And this has been shown to have a relatively stable visual acuity, good retinal thickness, and decreased fluorescein leakage area at 1 year. However, when it comes to center involving DME, there are two possibilities. You can have it with visual loss and no visual loss. Now, if we have patients with center involving DME and good vision, then the findings from protocol V are important, where on the surface we saw that there was not much difference whether you observed, you treated with laser or treated with aflibercept. But if you look closely at the results, you find that the best results in terms of achieving 20/20 vision, a stable retina, was with aflibercept. How do you apply it in real life? If you have a compliant patient with regular visits, you can always observe. If they need better vision like an airline pilot, then you would need to treat. And if there's poor compliance for follow-up, as we all know, laser is the option. Now coming to center involving DME with visual loss, protocol I showed us that ranibizumab had better outcomes than laser, but laser could possibly reduce the number of injections in eyes with better visual acuity. There is the risk of glaucoma with intravitreal triamcinolone. We know that after the year 1, majority of treatment can be weaned off or reduced. There's a temporary improvement in the DRSS scale. And probably ranibizumab does not have as much systemic risk, but we know all these trials have a strict inclusion criteria. Now, how do you compare the anti-VEGF agents? And we got this evidence from protocol T, where all 3 anti-VEGF agents have improved visual acuity. If the vision was good, there was no significant difference between the 3, but the better anatomical outcomes were seen with aflibercept and ranibizumab. If the vision was poorer, aflibercept was better at year 1, but equal to ranibizumab at year 2. Bevacizumab was definitely inferior. Now, when we look at how to define response, everyone says more than 15-letter gain, more than this much thickness, but we know it's not possible with all levels of visual acuity. And this exploratory analysis gave different thresholds for good and poor response depending on the visual acuity and the macular thickness, which was very easy to interpret. How do you apply this in the clinic? At the end of 2 years, the strong response to patients in terms of visual acuity and central retinal thickness, that response is maintained only in about 69% of patients. A lot of them, if there is only one category you're looking at, either visual acuity or CST response, there's a 50% chance of strong response after 6 months, and 75% of strong responders maintain at 2 years. And there is also a possibility of delayed response. Now coming to steroids versus anti-VEGF, there have been about 14 studies, and this was a meta-analysis. Anatomical response is good, but no specific visual benefit. You have to look at the potential side effects like glaucoma, cataract, and endophthalmitis. Most of the studies used bevacizumab, and most of them had triamcinolone. Now, protocol U combined steroid with anti-VEGF. versus anti-VEGF alone, the visual gain was comparable, but the structural outcomes were better. Now, this is the open label extension and endurance trials in DME, which were the 4 and 5 year extension studies. And they showed that around 4th and 5th year, you could go to an individualized dosing schedule based on the central macular thickness. It's good to know that a quarter of patients did not require additional anti-VEGF treatment beyond year 3, but they did occasionally require it, indicating that the disease process doesn't go away totally. What is more important, there is documented worsening of diabetic retinopathy once you're off the anti-VEGF injections, which is something that is significant. We have various treatment protocols, monthly PRN and then monthly followed by fixed, treat and extend, PRN and personalized treatment interval. I don't have time for all of them, but usually one would go to individualized treatment. Now coming to brolucizumab, these were drugs that were intended to have better results with a longer duration of action. There were 2 studies, the Kestrel and the Kite. And if we look at it, they were non-inferior to aflibercept at the end of 2 years. The Kestrel study showed non-inferiority, but if you look at the Kestrel study showed slightly better response with aflibercept 2 milligrams. And again, there was a certain proportion of patients with central foveal thickness less than 280, and probably the best results were with brolucizumab. However, and this is quote from the article, the risk of intraocular inflammation is significant and cannot be ignored. So again, the dual anti-VEGF agent, faricimab, in the Yosemite and Ryan studies compared faricimab 6 milligrams every 8 weeks following initial treatment with 6 monthly doses, followed by a personalized treatment interval against aflibercept at fixed 8-week intervals. And this had non-inferior gains. But if you look at the patients where there was absence of DME at the end of 2 years, the highest was in patients with faricimab every 8 weeks. And it was possible in a significant number of patients to extend the treatment interval to every 12 weeks or 16 weeks. And most of these studies, except probably the brolucizumab and the faricimab studies, have been utilized in the consensus statement from AIOS and BRSI, and they more or less follow the similar guidelines that are seen in the evidence that I have presented earlier, where they have the guidelines switching to intravitreal steroids as well, and also a role for laser photocoagulation. And subsequently, there's another publication from the Asian group, which again says that anti-VEGF is preferably the first line of treatment, dexamethasone in certain selected cases with high risk factors, and other treatments like laser and surgery depending on the biomarkers. Now, consensus is something, guidelines and something, evidence is something else. And there are 2 studies which tell us that consensus does not always agree with guidelines or evidence. And the study also showed that the definition of DME, the need for stable metabolic parameters, and the use of a second anti-VEGF when to start it was always controversial. And this was also seen clinicians versus AI in the study from Narayan Netralaya, which showed that when treating center-involved DME with good visual acuity, presence of coexisting lattice degeneration, renal disease and anemia, and a recent history of cardiovascular disease, there were clear disagreements. So to conclude, to manage your patient, it's important to know the patient first. Definitely systemic control is important with appropriate investigations. Proceed with treating as per available evidence and appropriate guidelines. Thank you very much for being here today, and I welcome you all to Chennai in July for our Retina Summit. Thank you.